All right, guys, so we're going to be talking about our MCI response. This was a presentation that was put out by the EMA and the Butler County Fire Chiefs Association about 9 years ago. And it's still very relevant today. We've had a lot of MCI training over the years, but this purpose of this is to familiarize a lot of our new members with what constitutes an MCI and also kind of what our plan is globally going forward. So again, our purpose is, as you can see there, provide structure to our personnel responding, because an MCI is very, very complex, right? The Any mass casualty incident, when we think of like an active shooter, when we think of a major motor vehicle crash, will absolutely tie up and tax our resources. So every fire department in the region operates an MCI a little bit differently because the definition of an MCI varies greatly. While we are blessed with pretty good staffing, we can handle a lot of different patients. That's not going to be the same as, say, a Trenton Fire Department or some of our other agencies that are within Butler County. Similarly, we cannot manage the same number of patients as the city of Cincinnati. So even with our robust mutual aid plans, we just don't have the necessary manpower initially to handle that kind of a response. Add to that the chaos, add to that the communication issues, and just the incident complexities themselves. There's a lot that goes into an MCI besides the simple basics of triage, treatment, and transport. So this will give us a little bit of a framework to give us those immediate resources, some prompt field care, and then the big thing of coordinating that with medical facilities so that we can move forward with our plan. So also during the MCI, so let's say that we have this major motor vehicle crash that happens on the interstate. That doesn't stop Chesterwood from calling with an injury from a fall. That doesn't stop Heritage Springs from calling. That doesn't stop someone with chest pain from needing 911 services as well. So there's also routine calls that are further taxing our dispatch center and taxing our agency for how we handle those calls for service. And at the end, we're trying to do the most good for the most people that we can possibly do. So how we get activated might not necessarily be very clear cut. So we might have a motor vehicle crash with multiple victims. Years ago, we had the Greyhound bus crash that went flipping up and down I-75 with 40-something people on board. That was a major MCI. We could have a large fire. We could have severe weather where a tornado comes through and blows down a bunch of houses or takes out a trailer park or two. There's going to be a lot of patients there. Building collapse, depending on the type of building that it is. Again, an apartment building, some type of a multifamily, or consider like places of assembly, a movie theater, a church, things like that. Acts of terrorism or civil unrest, rioting, for instance, looting. But also don't forget things like an active shooter, right? So if we have a gunman that walks into Lakota West and starts shooting up several classrooms, that is also going to be an activation. On top of that, our dispatch centers have been getting inundated with calls. You've likely seen how many times that our dispatch center gets inundated with just a simple fire. A car fire on the interstate generates a number of 911 calls. The same is going to be true with these types of incidents as well. So communications initially is going to be very, very difficult for us. But with that, we have to keep in mind that we have the propensity for an MCI every single day. If we think it is an MCI, activate our resources early, right? Just like a structured fire, if we think it's a bad fire, we call early, we can always cancel those resources. That's why we advocate for adding additional medic units if you think there's multiple patients. That's fine, we can always call them off. We're expected to maintain our own capabilities at predetermined levels to continue to meet local needs, meaning we shouldn't be browning out a lot of units on the daily basis, right? If we say that within Butler County, this is our standard deployment model, we should maintain that standard deployment model and adjust as necessary and adjust that with the fire chiefs within the county. We'll operate under NIMS. Hospital has their own hospital incident command structure for their responses, but we will operate under NIMS, so we don't really have to worry about that. Medical facilities and public safety agencies will do training exercises like this one and also the hands-on portion of this. And we should have an MCI plan, which we do. We can modify that plan or adopt the county plan, which the county plan is our plan, so it kind of makes it easy for us. And then EMS agencies will use mutual aid departments and have those MOUs in place like we already have. So how do we declare an MCI? So number one, it's used to notify EMS and also the hospital systems that we have an MCI in place. Remember that while we have our 3 ambulances and our 5 fire companies, there are also other medic units that are available to us via mutual aid. And as we can branch out and go to further and further medic units and get more and more people here, there is not an extra number of hospitals. So we have Westchester, we have access to Mercy Fairfield, Bethesda North, our normal hospitals that we transport to every single day. But just like we talked about, where an MCI doesn't stop the routine calls from occurring, this MCI did not stop that hospital from having stroke alerts, STEMI alerts, cardiac arrest showing up, trauma emergencies, all those other resources that daily compete with our needs in the hospital. So we need to declare an MCI early. That allows the hospital to start bringing in resources, shuttling people, and just preparing for this. So in the early stages, alert the system, which is called DisasterNet. DisasterNet is a communications tool that is basically run by UC Mobile Care Air Care Dispatch. So when we say activate DisasterNet, we will literally talk to UC Air Care via their dispatch center. What DisasterNet does is they start figuring out from all the hospitals what resources they can take. If we were to take 30 patients to Westchester Hospital, they would be completely swamped. So we have to consider and prioritize what patients go where. Also, that goes into that factoring is, well, what are the hospital's capabilities? So if it's a trauma MCI, like an active shooter, an MV motor vehicle crash, something like that, Westchester Hospital is a trauma center, so we need to take our trauma patients there. The next closest one would be like Atrium, and then after that would be like Fort Hamilton. Maybe our minor care or our less injured parties might go to Mercy Fairfield. They might even start going out to like Mercy West or Good Sam downtown, hospitals that are away from this, in order to not flood them with additional patients. So any responder can report an MCI incident. And so, like, if you look at our policies and even through the protocol, the first unit on scene, one of the first things they have to do during their scene size-up is say, is this an MCI? If it is, declare it, because that also brings an IMAT response. If you're the first medic unit on scene and you've got 10 patients, that's going to overwhelm you. So declare it as an MCI, establish command, and you're only going to be in command for a little bit until that IMAT response gets there and kind of takes it over, because there's a lot that goes into it that's besides just triage. How we initiate it is going through our dispatch channel. So on Fire Main, we declare it as an MCI, establish command, and again, that's how that goes through. And then try to give us as much information as you can. How many injured parties, if you can, the location, which is all part of our size-up modeling. Once we determine that it's not an MCI, we can cancel it. Hey, I was wrong. This is not an MCI. That being said, we don't want you showing up on scene and just declaring an MCI right off the rip, because that will activate a whole lot of things needlessly. Take the time to do a thorough scene survey. If you have 10 patients, 10 true patients, that is an MCI per our protocol. But if you have 10 parties that are on scene and only one of those parties are injured, it's not an MCI. So there's a difference of what those are, and it takes just doing a quick scene size of a quick scene survey like we do every single day to determine, is this an MCI or not. So once we do that, we have an MCI alert that goes out, and that goes through the communication center and DisasterNet. So what that does is it starts activating all the hospitals. The information that we provide is the type of incident. So is this a hazmat? Is this a large fire? Because again, that's going to start just kind of ramping up resources across Southwest Ohio. If it's a car crash, right, a lot of hospitals can handle that. If it's a structure fire where we're assuming that we have a lot of burn patients, now hospitals are probably going to be looking at, well, how many cyano kits do I have? If we're looking at traumatic burn injuries, there's not that many burn centers available. So who can take those? Estimate the number of people injured. That's going to fluctuate as the incident kind of progresses. If it's an active shooter, again, we're looking at a lot of trauma here. So, hey, what hospitals are trauma centers with surgical capability? Those are the things that DisasterNet's looking for, and they do that for us. This isn't something that we have to worry about on the scene. However, understand that the incident command system is finding all this out so that you can work and everything's being driven for the patient's benefit, right? We're doing everything we can to do the most good for the most amount of people. Again, this takes a robust incident command structure. So people always wonder, well, why are all these people coming to fill in all these roles that you're about to see that happens? So at the very top, we have the incident commander, just like we always have. We're going to need a staging area manager or someone to manage staging, because if we pull the plug and say, hey, this is an MCI, within the Westchester Fire Department, we have EMS extra alarm assignments. Just like we have extra alarms for fire, we have extra alarms for EMS. The next ramp up is for 10 to 25 patients-ish, and that brings 10 medic units, 2 engine companies, the medical director, and 2 helicopters. That's a lot of stuff coming right now. And if we have no plan of where to put that stuff, it is just going to amplify the issues of this scene. So we're going to need someone for staging. We'll probably assign someone to operations. And operations is going to be dependent upon what kind of incident we have. A hazmat incident with a lot of injured people from a hazmat release is going to require vastly different resources than, again, an active shooter. Beyond that, we might have a fire branch, a law branch. We might have a unified command structure if we're thinking this is like a big train derailment or something. So there's no set cookie cutter way to do this. Just understand that there are a lot of components that go into a mass casualty incident. Within that system, however it's broken down, will be an EMS branch director, likely going to be Chief Whitty. However, depending upon the incident complexities, depending on availability, depending on what's going on in how fast this is progressing, this could be a company officer, this could be another chief officer, this could be a person off a medic unit. So just because you have or don't have rank does not mean you can't be thrust into this position. So that's why we're going over this broadly so everyone can understand. In the battalion car and in the medic units, we have packets for each of these positions. So even if we did throw you into this EMS branch director, you could open up the packet, quickly read what your roles and responsibilities are, and that kind of gives you a just-in-time training / briefing on what you're expected to do. Under the EMS branch director, their job is to handle all things EMS. So in this mass casualty incident, they are kind of the most important person. We need a triage group supervisor, a treatment group supervisor, and a transportation group supervisor. So we need 4 people right off the rip under the incident commander to start managing this incident. That's even before we start touching patients, right? We're already going to be doing triage. We're already going to be doing starting treatment plans, but we need 4 people to effectively manage the workers in the field doing the good things. The triage group supervisor is exactly what it sounds like. So their job is to monitor triage. And remember that we have 4 levels of triage: red, yellow, green, and black. Again, we have a job aid for you. So this is the job aid that's been provided, and walks through, the alarm assignments. Do you have the disaster net open? And so again, we talk about this disaster net and this communication model. Again, what they do is just, again, helping us. They're going to be the ones getting on the radio on their side of the system and calling around to the area hospitals to see how many patients they can have. And it'll simply be disaster net to Atrium Medical Center. What can you take? And Atrium will call back and say, hey, we can take 2 reds and 3 yellows. And disaster net writes that down. Then they'll call Westchester Hospital and they say, hey, no reds, 2 yellows. And they write that down. And they say, hey, Mercy Fairfield. They'll say, hey, 1 red, no yellows, but I can take 8 greens. Cool, and they write that down. Then they go to Bethesda North, UC downtown, Children's Liberty, Children's downtown, Christ, all the hospitals, just to see what their availability is, which fluctuates minute to minute. They log all that and they'll radio back to the transportation officer and tell you, hey, your patient is going to be transported to X. So we don't have to make the decision on where they go. DisasterNet will do that for us, which is a huge benefit to why we have to activate this system. So the treatment group, they report to the EMS branch director, and their job is to supervise the treatment plan. So remember, just like we have all of our patients triaged, which triage will go very fast. Triage will be done within the first 5 to 10 minutes usually. Now everything turns into treatment. So we need 3 treatment areas: red, yellow, green. Naturally, the reason we don't have a black treatment area is because those patients are deceased. Incident command, working with EMS branch and ops, will figure out what we do with the deceased. Do we move them or leave them in place? It depends on the incident complexities. Typically, they're left in place initially, which could be a big thing for providers, that you're going to have to work around deceased victims to save live victims. That's a very, very difficult thing to do, but that just might have to happen. Within the treatment group, again, red, yellow, green. And so not only are they supervising the treatment, but they're considering the logistical needs for each of those zones. For instance, in the red treatment area, we know that the red are the most immediate, most critical patients. So things you're going to need in that treatment zone, you're going to need a lot of tourniquets. You're going to need a lot of chest seals. You might need some BVMs and some oral airways. What we do not need there are like IVs, because these patients are going to be quickly treated with very, very basic care, thrown into an ambulance and transported fast in an ideal world. If it's going to be delayed, add the IVs. Your immediate treatments patients should be getting off the scene fast. That's why we don't want to bog them down with a whole lot of procedures. It should be fast, down and dirty care. However, in the yellow treatment section, these patients are delayed. They're going to be a little bit. So that's where we might need to start stocking some oxygen bottles, some non-rebreathers, some cannulas, some more invasive procedures like IVs, pain meds, things like that. In the green treatment area, they're considered kind of your walking wounded or your minor patients. They're still injured, but we might consider things like splints there, basic splints, sand splints. We might consider things like blankets, bottled water, stuff like that. So consider that if you're the treatment group supervisor, and where are you getting this equipment from? One thing that's helped in a lot of MCIs, if you study them, is establishing a collection point for equipment or an equipment cache. So simply getting on the radio and saying, hey, as units are reporting for work, everyone bring up your first in bags, bring your trauma bags, bring your drug bags, and we're going to sit them all in the same spot. Understand that initially for an MCI, our medic units are probably not going to be transporting anybody. So we're going to be working out of our bags and out of our equipment. So we'll have to just figure out the bags later, but if they all get blown apart and equipment's used, then they all get blown apart and equipment's used. But that way you have a central point for equipment, chest seals, needle decompression needles, whatever we need out of one spot versus running back and forth to ambulances, back and forth to fire engines, which is just delaying care. Again, they have a job aid, which helps you through that. The other thing that every patient needs when they come into your treatment area is a secondary triage. The reason we want a secondary triage performed by somebody else is the same reason we do a secondary search. In a primary search, you're going to be amped, things are going to be different, things might get missed. The secondary triage performed by somebody else, they're a little bit removed from the incident, they arrived a little bit later, you're still amped up, but you're able to go through a more thorough assessment. So you're doing the secondary triage to make sure they're categorized right into the right area, and also to make sure that, hey, did anything change, right? Did that delayed patient who was yellow now turn critical into red, or vice versa, because of some basic treatments that you did or basic treatments that they need? Again, the triage group supervisor, they're seeing that triage process, it's going to go fast. So once the triage is done, they start moving patients into the treatment area, and then they can be reallocated to another area, probably to the treatment group, because that's going to eat up your most amount of resources. A job aid for them. Typically, you're not going to have time if you're the triage group supervisor for a job aid. So a lot of the MCI training goes towards triage, because you're not going to have time to pull this out. You're going to be pulling up and starting to sort and figure out how many patients you have. Probably the second most important person besides the branch director as far as overseeing everything, but definitely the busiest person here, is the transportation group supervisor. This guy's job is to figure out where the hell all these patients are going. Again, DisasterNet's doing that for us and telling us where they're going to actually go, but you're coordinating how they're physically getting there. So you have a patient sitting in the red treatment area. What medic unit is taking them to where? And so you're tracking all that. So it might be something just as simple as, hey, medic 62, you're taking this patient to Atrium, and that's what DisasterNet's telling you to do.
Engine 34, medic 74, abdominal pain, 8239, Jamie's Creek Lane, 8239, Jamie's Creek Lane, Cross Street to Fulton Way, EC 404, 2006.
Remember that through this entire process, you're not able to get information, right? We're not sitting there doing an EPCR on every single one of these patients. We simply don't have the time. The way we're tracking all these people is through triage tags and through the barcode that's on those. So that barcode you're going to write down and know that, hey, patient 0129970 went to Atrium with medic 62. The patient tracking coordinator on the backside of this is going to marry that triage tag with a patient who gets an EPCR done en route by a mutual aid medic unit and puts those together, loaded into the system on the back end of this so we can figure out where everyone went. Think of like an active shooter again at a school. We're not going to be giving these kids' names or ages or anything like that. We're just going to know that we have 15 kids who are shot that need immediate care. They're going to get assigned a barcode number, sent out to a hospital. Their parents are immediately going to know where they went, what's going on. The way we figure that out is by matching this stuff up on the back end of the system. Again, a supervisor checklist for the transportation group supervisor. This is huge to consider because not only are you considering the ground-based units that are going out,
probably should take precaution. The patient believes she may have seen it.
your patients that are going out by ground, again, are going by mutual aid medic units. Those medic units might be coming from a distance away. When we had the bus crash, we had medic units from Hamilton County way up into Liberty Township. So when you say, hey, go to Atrium, a Sycamore Township medic unit or a Loveland Sims medic unit is not going to know what that means. So not only are you going to have to tell them where to go, you might have to give them spot directions on how to get there. On top of that, air operations falls under you. So which patients are going to get helicoptered out? Which means we're going to need landing zones. We're going to need to figure out how they're being transported to the landing zone. And you're going to need resources at that landing zone, like an engine company, as a just in case. If we have multiple helicopters inbound, which is very possible, again, on the bus crash, we had 6 at the same time, all landing on the highway, it turns into a little mini airport. So we have to figure all that stuff out. Like I said at the beginning, mass casualty incidents become very, very, very complex, more from just triaging all these patients, but all this big end stuff that the command staff is there to hopefully do for you. But this is also going to be something that is happening very, very fast in real time, oftentimes before a lot of the command staff can get there. So then we have a communications coordinator. This is someone like a Lauren Duffy at the hospital, or associates of Chief Whitty's that helps to work through the communication side. DisasterNet takes care of a lot of this for us now, but they're just making sure that our communications process is good, that we're sending the patients to the right place, and then we also are contacting medical control as needed. The nice thing about our alarm assignment is that our medical director is coming. So if we declare an MCI, our medical director is going to be en route to that when we pull the EMS second alarm. Again, a job aid for that as well. The tracking coordinator, like we talked about, for the family reunification. So figuring out where each patient went, loading that in. We might liaise with the Red Cross for family reunification, and that just depends again on the incident. If it was a large storm, tornado came through and took out a bunch of houses, and we have hundreds of people that are displaced, that's a Red Cross thing. If it's a few patients because of an isolated incident, then it's something that we would probably handle as well. Again, more checklists for that. The medical supply coordinator, something we probably are not going to stand up unless we start running out of supplies. So examples where we've run out of supplies, again, a large storm, maybe like the fire in the Bronx where FDNY medics are just intubating a lot of people. We're just blowing through ET tubes. That's where we need to stand up a medical supply coordinator. We have access to things in the county, such as the MCI trailer, which are going to bring a lot of backboards, a lot more splints, a lot of like gurneys and patient movement devices. But again, this is where we have a equipment cache or a collection point for all of our equipment, so that we can work out of all of our bags simultaneously. If we start realizing that, hey, we're low on oxygen, again, think outside the box to how many bottles are on each medic unit. There should be at least 3. How many is on each fire company? There's at least 1. So start collecting all those and starting to use those. As we start losing supplies and this incident is still ongoing, this is where the supply coordinator comes in to go back and get us new bottles, find us new cylinders, whatever we need to do, or start robbing our mutual aid companies of them is an option as well. The Moore branch director is exactly what it sounds like. Their job is to take care of the deceased and to make sure that the investigation into their deaths and how they are tracked and where they're taken after the incident is taken care of. This is typically run through the coroner's office, so again, not anything that we have to do, and it's probably going to be run through our unified command process with our police department. But they'll document any movement of deceased bodies. We may have to liaise with these guys just because of if we had to move a body for patient care or move a body so we can move a patient out of that area. That's something we just have to do. But it also prevents improper removal of bodies, parts, personal effects, just so that the families are notified effectively and that everything is taken care of on that end. So again, we have a lot of forms. These were developed with an MCI management tactical worksheet. These are in the battalion car. These are also in all the staff vehicles, and we'll double check to make sure these are also in the medic units. You can see some of the alarm assignments that are there, so our resource needs and request appropriate MCI level. Making sure that these resources are available to us, like the MCI trailer, air medical, IMAT system, like everything that's going on. We can make contact with 7Com to open up DisasterNet or direct them ourselves, and making sure that that is being monitored and tracked. The treatment area logs are how many people you have in each one. It has an area for the patient name if you know it, but the big thing is going to be that triage tag number. We can link that to the patient name later, but it's very simple. When did they come in and when did they go out? Remember, your red patients should be staying in the treatment area very, very little time. We should be bringing in units into the transport area, getting them out of staging, requesting them in, loading them up, and then sending them out. Once we have our units staged, a good rule of thumb for this as we go through is to kind of bring in trucks 3 at a time. So the first 3 medic units in staging respond to the scene, receive 3 patients, and they're going to hospitals X, Y, and Z. They leave, give me the next 3 medic units in staging. We don't want all the medic units to just show up on scene, because what that does is it jams up your inbound and outbound routes. If we are responding to an MCI, so let's say that we have this same type of crash, but now it's on bypass 4 of 129, and we have 10 patients out in Fairfield Township, we are going to be the transport groups for that. So stay disciplined to your assignment. Don't freelance, because as soon as you do, that just starts really messing up this entire already complex, messed up system. The hospital capability and patient tally sheet. This is just another form that we have available to us within the command system. Again, DisasterNet's going to do this for us, but this is just another way to track and just double check and verify, because people are going to be asking, hey, what hospital? How many can they take? And you can just have this written down quickly. Our staging unit log, again, something just to quickly write down. A lot of this is probably going to be done on a dry erase board or a marker sheet in the command car, or just on pen and paper, but we have this form to us as well to kind of make it a little nicer. And then how do we triage? So this is the START triage system that's going that we'll be doing with our hands-on portion. And we use what's called START triage using what's called the RPM method. So RPM stands for respirations, perfusion, mentation. You do not have to go through all three of those things, because the way it works is we pull up to an MCI, we recognize that it's an MCI, we declare it as an MCI and establish command and request our additional resources. From there, your next job is to triage, because the thing we want to know the most is how many people do we got? Do we have 10? Do we have 40? Do we have 100? Do we have 1,000? Those are all issues that we have to figure out. It's much easier to treat 10 than 100, but it's easier to treat 100 than 1,000. So try to figure out how many patients we actually have. The first step to this is to get on your intercom, get on your PA, shout really loud, whatever you have to do to say, hey, if you can hear my voice and you can follow directions, go over here. Identify an area that's safe and away from the scene for people to move to. People are going to go congregate to that spot. Those are your green patients. Do not lose track of them. They are still patients, but we're going to get to them later. What's going to happen is in most MCIs, your patients are going to move out to that area. And so if you had 20 to start with, now you might be down to 8. Now you might be down to 10. It's still a lot of people, but it wasn't 20. So a majority of your patient contacts are going to be minor, and they're going to move off to the side. From here, you're left with those that cannot self-ambulate. They can't move. So this is where RPM comes in. We walk up to the first patient we encounter, and we see, are they breathing or not? If not, we go down the decision tree of open the airway. If they start to breathe after we open the airway, they're tagged red, and we're done, move on. If they don't start to breathe, we tag them black, and we move on. Now we're done and going to the next patient. We get to the next patient. We look and see if they're breathing. This time they are breathing. Is it between 10 and 30? If it's under 30, or if it's over 30 times a minute, or if it's under 10 times a minute, they are tagged red. Move on. If it's between 10 and 30, we move down to perfusion. And all we do is we check it for a radial pulse. Do they have one or not? If we don't feel a radial pulse within a couple seconds, tag them red, move on. The reason for this, again, is that, hey, we're aware that you have to have a certain blood pressure to generate a radial pulse. We can also look at cap refill. So if their cap refills increased over 2 seconds, they're tagged red because they're assumed to be in shock. If we get to our third patient, we check to see if they're breathing. They are. They're breathing between 10 and 30. We go to perfusion. We feel a radial pulse. We go down to mental status. If they can follow simple commands, which means touch, put your hands up, touch your head, touch your nose, whatever you tell them to do, follow a simple command. If they can successfully accomplish that, we tag them yellow and we move on. If they cannot, they're tagged red and we move on. The caveat to this is start triage is not used in RTF. So when we deploy a rescue task force for an active shooter event, you are not doing start triage in the hot zone. What you're doing is a different type of triage system that we'll go over later. But the RTF's job is to triage the number of patients. You use a modified version of this, but you also deliver simple care. You'll put chest seals on, you'll put tourniquets on. Whereas in a true MCI, you're probably not doing those things right away. We're simply getting a patient count and a tally. The initial triage team, as they tally this up, is going to be wrong. The Jumpstart triage model is for pediatrics, and the only thing that changes here is our respiratory side. So instead of being between 10 and 30, it's between 15 and 45. If it's over 45, it's immediate. If it's less than 15, it's immediate. So we tag them red. The only other thing that changes here is if your patient starts to breathe, if your patient is not breathing, we open the airway. We see if they have a pulse. If they have a pulse, we give 5 rescue breaths. After we give 5 rescue breaths, if they start breathing on their own, they get tagged red. So pediatrics get rescue breaths, adults do not. The other difference is the numbers change from 10 to 30 to 15 to 45. Everything else is essentially the same. As we start triaging our patients, again, you're going to be wrong. Your patient count is going to be absolutely incorrect because you're amped, because there's a lot of sights, sounds, blood, stress, all that stuff. You're going to have a higher number of red patients, and that's okay. That is why we have a secondary triage. Probably an engine company coming in from a little bit of ways away to set up these treatment zones. As soon as the patient arrives, they get re-triaged. We use triage tape, which are on our RTF kits, because this is the easiest thing to do. We will get these replaced by a tag in the triage area. So as they come into the treatment zone, they'll get at the actual barcode tag. But as an initial field care thing, tape works. Put the tape around their wrist, put the tape around their ankles, wherever you want. The problem is that if you hand a patient a tag, the tag's going to blow away, the tag's going to get blood all over it to where you can't read it anyway, the tag's going to go missing, which screws up everything and the reunification process, where that patient go and tracking. It just really puts a bad situation worse. Patients won't do that with tape though. For whatever reason, in multiple studies, they just don't do that. So just tie this around their wrist, tie it around their ankle, whatever, and now they have a definitive color. They'll get the tag on the treatment zone where we can kind of control this a little bit better as we start rendering the scene safe. Contaminated patients used to get this. This was part of the county plan. However, we have never had a contaminated patient to be able to use it. So after they've deconned, the stripe tape will be removed and replaced by another one. That's what this one was for. Again, they come into the treatment zone, they get the tags. So these are our start triage tags. We peel off the bottom. So the bottom side where the colors are perforated. We peel off the ones we're not using. And then the tag is kept with the number on it. The side of it is also perforated, and that has a tear off for you as the transport officer to keep. So as you're going through this, you should have a bunch of little tags with numbers on them with, and those are your patients that have gone out. So we can just take those serial numbers, match them up to the patient care reports, and now we know where our patients went. If we start bringing helicopters in, which is very possible, these are regional air resources within the tri-state area. So we have access to a lot of helicopters out there. What happens is some airspace is controlled by Indianapolis, some is controlled by Cincinnati. So who's control? An air boss. Just like we had with the bus crash, we had issues with trying to coordinate radio frequencies with all these helicopters. What we found out is if we get the first helicopter on the ground, even if it's a UC talking to Care Flight, UC talking to Air Evac, whoever, they have each other's frequencies. So the first helicopter will essentially become an air boss, and if we cannot provide one. An air boss is simply someone who can go over and manage all the helicopters and where they land. Think about a landing zone. We want a 100 by 100 area. Times that by 6, and you need a 600 by 600 area to start figuring out where all these helicopters are going to go because of the rotor blades and everything else. These are extremely hazardous situations to be in. Fortunately, the helicopter pilots are very well trained in this. So what ended up happening was Air Care 1 landed on the ground, established themselves as air traffic control and as an air boss, and they landed the next 5 helicopters for us, and we didn't have to worry about it. So that is an option that worked very, very well for us, and that's something that the helicopter pilots can do. Again, request the pilot function as the air boss, so they will take that for you. The other benefits is the flight services are informed to come into an MCI. They'll bring extra stuff to them, right? So that medical supply coordinator, if we know it's a MCI from a large fire or a hazmat incident or whatever, they're going to start bringing airway equipment, tagging equipment. They might bring blood, TXA, whatever they need to manage that. If it's an active shooter event, again, they might be bringing all this stuff with you, which is all things that you're going to want to be showing up because that's what the patient needs anyway. We talk about chem packs. Chem packs are used for nerve and organophosphate poisoning. So this is like not bioterrorism, but chemical weapons attacks. Chem pack supplies are out of Dayton and they come from the Ohio State Highway Patrol as a push pack. There's an entire plan for if there was a nerve agent attack on the county, which involves the sarin, tabun, somon, and VX gas. They come with atropine and 2-PAM hydrochloride, which is the antidote for a nerve agent. It's going to take some time for it to arrive. That's why we have duodotes on the medic units. Those duodotes, those little gray boxes that you see on the medic unit, you're like, what are these for? Is exactly for this thing right here. These are the signs of a nerve agent or organophosphate poison, so we use sludgeon. The odds of us running into this, if we start seeing a lot of things like this, start thinking of, hey, is this terrorism? You can have these same effects from organophosphate poisoning, like farms and pesticides and things like that. The chemical makeup is very near identical rather to chemical weapons. However, you can have this accidentally, like on a farming community, or you can have this as an intentional terrorism thing. If you start seeing sludgeon symptoms on your patients, start considering duodotes, and since we only have a limited number of supply of those, consider a push pack activation. Again, this is the what the 2-PAM looks like. So one side is 2-PAM hydrochloride, and the other side is atropine injection. We carry on the bottom right the duodote, which is a simple auto injector. Anyone can administer the Mark 1 kits, which is the two-sided or the duodote, so you do not have to be a paramedic. You don't have to call medical control for it. If it is a known or suspected exposure, you can go ahead and send it. However, once that happens, then you want to start getting on the phone and let them know that, especially if you have an MCI with this, that hey, we're deploying Mark 1 kits. Duodotes are also used for yourself as well. So the big thing is protect yourself and your patient. Well, wear nitrile gloves and respiratory PPE, especially if you think it's a chemical weapons attack. We'll need to set up a decon corridor, and now this incident just got more complex because we'll have an entire hazmat component, a decon corridor, all these things we're going to have to do to mass decon a lot of affected patients. That's assuming that our patients actually stay here. As you can see, over 80% of the Tokyo sarin patients, this was back in 1995, a terrorist group in Tokyo, Japan, deployed sarin nerve gas into the subway system there and affected a lot of patients. However, over 80% of them self-transported. That's the same statistic that you see across from any major MCI involving hazmat. The big statistic being is that a lot of these patients are not going to stay. They're just going to get in their cars and go to the hospital. What that's going to do is it's going to jam up the hospital system again. So again, the heart attacks are showing up, the strokes are coming up, and now you have 40 people showing and saying, hey, I was exposed to nerve gas. That is going to shut down hospital operations in the region. So our resources where you can get these antidotes, first tier is our regional drug bags in hospitals, like we carry the duodotes now. Second tier is the MMRS caches. So this is where the push packs come out of: Akron, Cincinnati, Cleveland. Second and third tier are the chem packs, where it comes out of Dayton. And then third and fourth tier is where you get federal activation of these things. Should never have to get to that area, but there is a whole federal ESF plan for that. When we call chem pack, I think 100 of them come at a time, so shouldn't have to go that far. This is what the chem packs look like, stored up at Miami Valley. And again, it's provided by the Department of Homeland Security, Health and Human Services, the CDC, and the Strategic National Stockpile, which is all the federal side of that. When we need to deploy a chem pack, we call the Joint Dispatch Facility. We request an EMS chem pack from the incident commander, and that'll get routed. What happens then is law enforcement personnel respond to the host hospital and pick up a portion of it and then bring it down to you. So that's going to be coming from the Ohio State Patrol, traveling at a high rate of speed down I-75 with the chem packs. They'll take the remaining forms for use when transferring custody at the delivery sites. They should be delivered or physically received by the staging officer or the medical supply coordinator on the emergency scene. So this takes a while to mobilize, but if we need it because of a large MCI like a terrorist attack, we have this capability available to us, as does the rest of the state and the USA. Make sure that it's based on close proximity to the host hospital. So host hospitals do change. They might choose to retain some of them, just because if they say, hey, we know this MCI is going on, we know we're going to get some patients self-report to us, so they might elect to keep some of their Kimpacks back. For 454 patients, this is what you start getting. So this is the requested quantity and how that looks. And we talked about communications. Our radios are able to do an MCI notification, so we can send that out. The EMA will likely take care of a lot of that for us, but again, we talked a lot about DisasterNet. We still want to do our local hospital, so if we maybe only have a few patients, we're only going to be utilizing a couple hospitals. We still want to utilize good communications between the hospitals just to let them know that's going on. An MCI within Southwest Ohio is still going to stress hospital systems across the region. Just because it doesn't happen in Westchester doesn't mean that's not going to have a direct impact on our operations and our ability to care for our patients. The current channel is E or Echo 15. That's the ER talk group. So we can get on there. That's the same channel the hospitals are supposed to be monitoring. So this is the individual hospital channels. All you do is get on the radio and advise hospitals the nature of the event. Hey, this is Westchester Command. We have a mass casualty incident on I-75 involving a multi-vehicle crash. Respond to the ER, change the channel to the Butler County ER talk group, and then repeat that message 3 times. Again, the DisasterNet's a tri-state regional asset, so that's Ohio, Kentucky, Indiana. It works very, very, very well, and then they just kind of take care of stuff for you. Situations that we're going to use that: terrorist incidents, MCIs, hazmat incidents, hospital evacuations, or a major mobilization of federal resources for MCI capabilities. The radio is one component. The other side is the SurgeNet internet-based component, which is housed on the Greater Cincinnati website. It's local MCI National Disaster Management System data. This is where SurgeNet looks at and tracks real-time hospital capabilities. So they can tell you exactly how many beds they have. The last time that we used SurgeNet in this capacity was during COVID. So we were able to see what the ICU beds look like, what the ER beds look like, and we were using SurgeNet. And we actually used this on a bigger level for about 2 years during COVID. The scene commander, again, hospital. The hospital system or the dispatch can request activation of DisasterNet. Net control or air care dispatch can open up the net also, and that's the easiest way for us to do it. We just call air care and say open it up, and they just do it for us because that's less off our plate, and now we can manage the incident. Once we notify the communication center to open the net, they will start working everything to work. The scene advises the number of patients, adult or child, and triage color of the patient. From there, DisasterNet will take care of everything else. So all we're going to say is, hey, I have 13 adults, 13 red adults, 6 yellow adults, 4 green adults, 3 red children, 2 yellow children, 4 green children. And they're going to take care of everything else. So start figuring out the capacity for you, and then tracks where they start going. Net control verifies the destination of incoming patients, logs the transport. They'll figure out the number of victims remaining, and again, just takes a lot of that headache off of us. This is the hospital capability chart out of 2015. So this has changed quite a bit in the last 9 years. However, this is just looking at an example of what the receiving capacity looks like. Again, they're working this in the back system, so we don't have to do this in the field. After the event, we close the net. Hospital reports totals to net control of who went where, and then they can work with incident command to start working on the after action report. As far as our resources that we have, again in the county, obviously the Butler County Hazmat Team, our local hazmat team between Westchester, Middletown, and Hamilton. We have Tech Rescue, Swift Water Rescue, EOD, all the things that you see here within the EMA system and Butler County Special Operations. All these can be summoned, not necessarily as specific resources, right? We don't need a bomb squad on scene of a car crash, but Tech Rescue is an example of an activation that we can do just to bring more personnel to the scene. So again, the presentation here has been 9 years old now. There have been changes within the county. However, it's still very relevant as to what a lot of our operations and a lot of our capabilities are within the county. There's been nothing but upgrades and enhancements from 9 years ago to now. How we still triage and how MCI management works within our system is still very relevant today. Thank you guys for tuning in. I sincerely appreciate it. If anyone has any questions, do not hesitate to reach out to myself or Bureau Chief Whitty. Thank you guys so much.